Pushkar Lele from Nasik. I have been doing head and neck surgery and voice surgeries for some time, and I really appreciate the organizing team of Team ENT Train workshop for inviting me to speak on narrowband imaging. Some of you might have heard me speak on this subject, but it's a very upcoming subject, and I think that all of us should be trained in this, and we should be using this in our OPDs every day. So let's dive right in and say what is narrowband imaging. So narrowband imaging is an optical image enhancement technology. So as we know, to put it in a very basic way, this our color spectrum is can broadly be divided into RGB, right? That is red, green, and blue. These are the three colors which make up all your colors. Now, narrowband imaging is a patented technology by Olympus. I'm not promoting Olympus, but that's the company which has really made it popular and really developed a lot of good equipment to do that. But there are others who are using similar technologies. So each one, according to his liking, can use technology from any company and achieve the same results. So as you can see, this is the underlying principle of narrowband imaging. So, preferentially, some color spectrum is passed through the filters. The other colors are blocked. Now, according to the wavelength, the different colors are blocked. So, these blue and green, they preferentially light up some vascular patterns in your mucosa. And as you know, that there is something called as tumor angiogenesis. The edema also brings in a lot of vasculature. So any diseased portion of the mucosa will show up with a different vascular pattern. That is the basic fundamental of doing narrowband imaging. And that also the vascular patterns will develop way before you actually see a tumor. So green and blue will be uh, absorbed at the deeper and the superficial layers, and they will appear bluish and brownish. The deeper and bigger vessels will appear a little brownish. So this is another a slide showing you the same thing. The blue is the shortest wavelength, the red is the longest wavelength. The blue and green passes through, the red is blocked. And this is how you get a narrowband imaging image. Naturally, the most notable application of this technique is in the early diagnosis of malignant lesions. So people have come out with various classifications. Again, the basics of narrowband imaging remain the same. You're looking for abnormal vascular patterns to confirm your findings. So the most important word here is to confirm your findings, right? So you need to be really good at your endoscopies, your flexible scopies. You need to really have that index of suspicion and use this technology to confirm or disprove your diagnosis. Now, the most popular classification was done by Nee and others. They have also come out with some different couple of classifications. And the European Laryngology Society has also come up with the classification. Now, it's suffice to say that you don't need to get confused with all these classifications. And well, the most popular classification is the NEES classification, and most of us do stick to that. So in this, you see patterns from type 1, 2, 3, 4, and then 5. And the 5 is divided into three parts. Now, I'm not describing them. I will just go ahead and show you some pictures so you will know. Of course, the pattern 1 is a normal pattern, normal vasculature of your vocal cords as you see them. Okay. Now, this is a type 2 pattern. So if you can appreciate that the vocal cords are a little edematous with dilated blood vessels. Okay. And this portion here is actually a vascular polyp. Now, this swelling, whether it's a cyst or a polyp, is laid to rest with this kind of bluish blush that you see, and which tells you that yes, this is a vascular pattern. You're ready for the surgery, knowing very well that this is going to be a vascular lesion. This is a type 3 pattern where both the vocal cords are plastered with the leukoplakia, the white patch, and no vascularity. I mean, you cannot really appreciate any vascularity below this. So you need to call it a type 3 pattern. Unfortunately, you cannot comment on the vascular pattern at all. But what you can see is that the surrounding areas do not show any abnormal pattern. So we are going to label this as a type 3 and very likely to be a leukoplakia without an underlying malignancy. But the histopathology will confirm. Unfortunately, if you have some portion of the vocal cord which is normal, it is you have more confidence to say that this is indeed a leukoplakia, which is this case. Now, I'm sure that you'll appreciate that this is a nice leukoplakia here, and uh, okay, let me see if this again. You can see this is a leukoplakia here on the vocal cord, and you do not see any vascular patterns, so to say, which are abnormal. No IPCLs. We have not yet talked about IPCLs, but these are fronds of vessels which you can see on narrowband imaging, and I will be telling you what the IPCL is. But you're not seeing anything abnormal, so this is still a type 3 pattern. Incidentally, I don't know whether you noticed this, but there is one cystic lesion here. And this we know is not a polyp because there is no blue flush in that. And this is, there are dilated vessels on the surface, but this is a cyst. So now, I will just, and yeah, okay. And we're here. So you can see there is a lesion here. And now you can see this small areas where you see the color coming in, like the bluish or the brownish color coming in. And these are actually vascular fronds. These are vascular neovascularization changes. And you get these spots, so to say. And these are called IPCLs, or the intrapapillary capillary loops. And so these loops can be very fine with small loops, or you can have big splashes. Uh, you can have wandering vessels here. So depending on what it is classified as a type 4, type 5, type 5A, B, C. Now, this is a type 4. Now, it's a visual perception again. Sometimes you get very fine IPCLs. Now, some people are going to call this as type 4. Some people are going to call this as a 5A. But this is definitely an abnormal vasculature, right? So this is very likely to be a malignant lesion. Of course, your pathology will confirm this. This is a very interesting slide because you're seeing big splashes here, which is type A. However, incidentally noted is these wandering vessels in this area. I don't know whether you can appreciate this, and I hope you can because I've just increased the brightness of my screen. And these wandering vessels, in fact, are called meandering vessels. So when you see a picture like this, I'm showing this to you as a image of a type 5A pattern, but a disease can have multiple types of patterns. And when you report this on in your flexible endoscopy report, you need to say that the right vocal cord is showing a type 5A, and the left vocal cord and the anterior commissure is showing meandering vessels, which is type 5C. So this is again a type 4 pattern. You can see fine some abnormal vasculature here, and there's an obvious growth here. The meandering vessels, as we discussed before. Now, I told you that there are many classifications. So this one is the European Laryngology Society classification. So what they say is that the longitudinal vascular patterns, if you have dominant longitudinal vascular patterns, they're likely to be benign lesions. However, perpendicular and haphazard vascular patterns are more likely to be disease, which can be either papillomatosis or carcinoma in situ or malignant lesions. Another lesion, which is a right vocal cord growth. Now, see this. This is a, okay, and okay. Now, this is a small video which is showing you the right vocal cord growth. And this is the narrowband imaging showing you an abnormal vascular pattern here. And this mass is a malignancy. Similarly, a lot of people get confused with this type of a granuloma coming on the larynx, and then these are biopsied and these are treated and these are removed. And actually, if you see the narrowband imaging, you see that these are non-vascular granulomas. They're typically presenting on the medial surface of the arytenoid, and they are obviously contact granulomas. The treatment for this is not surgery. The treatment for this is speech therapy, and in extreme cases, injecting Botox and partially paralyzing the vocal cords so that they get rest and they heal on their own. Recurrent respiratory papillomatosis. Now, the application of narrowband imaging is in identifying the papillomas and also identifying the other structures or the mucosal areas which may have papillomas. So, again, they get papillomas which are more like type 4 papilloma IPCLs. I mean, the narrowband imaging gives you patterns which is more like type 4, except they are very fine dots, and you can make out the difference very well. So you can see that this is very fine dots, and you can see the rest of the mucosa is okay, and you don't have any papillomas. So this is confirmed on the laryngoscopy. But if you see the previous picture, the other vocal cord also has disease here. So both the things were removed with the Seurer laser and keeping the ligament preserved, and the patient was sent home on the same day. Well, now, this is a patient which showed a very aggressive disease, so to say, and you can see that the vocal cords are edematous, and there is a large mass which is occupying the subglottis. Okay, sorry for the lot of movement, but the patients sometimes do not cooperate. Okay, and you can see there is no abnormal vascularity seen on narrowband imaging in this. I will pause the video when you can actually see have a good view of the larynx. Okay, and let us just go here. I think this is a better way of doing it. So you can see this is a grossly edematous larynx, and there is a lot of edema here. There's a mass which has very little patterns, so to say. And this is papillomas with a granuloma in the subglottis. So you can make out that this is a different thing. This is not a malignancy, and you are prepared beforehand to treat this patient. Now, this is another patient with a leukoplakia on the vocal cord. Now, these are diseases which keep on coming back, but when you're doing kind of narrowband imaging, you know if there is any vascularity or any change which may suggest that this is now turned malignant. Okay, this was again a excision done. Uh, well, we are generally not very aggressive in this area, but some mucosa is preserved here, which is not very obviously seen. But you need to be very careful with this type of excision. So this is a picture which I had shown before, and I do show this video to a lot of residents, and believe me, everybody misses that small cystic lesion in the on the vocal cord, on the right vocal cord. So that was polyp or a cystic polyp with not with too much of vascularity. So this was the right vocal cord with anterior growth. Now this is an intra picture of the same. And so when you're doing a laser excision, the it is important that you get access from all sides for the tumor. And you might have to change your scopes, might have to change the position of your scope all the time. The amount of uh, pressure that is given on the larynx and the different techniques to do it, of course, beyond the scope of this talk. But a lot of experience and a lot of tricks need to be learned to get going with this kind of tumor. Sometimes you have to take multiple margins to be sure that got the whole thing out. Uh, so what we generally do is wherever we feel the margin may be compromised or maybe close, we just excise a separate margin and send that for histopathology. And you need to draw the pictures very well. Also, these sections that are removed can be inked with methylene blue. And believe me, this methylene blue can be seen by the pathologist. So this was an exophytic growth, not going too much into the substance of the vocal cord. And this is a complete excision with negative margins. So, in my opinion, the very important role of narrowband imaging is in monitoring your patient's post-op. Now, this is a gentleman who was operated 20 years back for a stage 2 vocal cord cancer. He was almost going into the anterior commissure that time. And this gentleman came with another patient 20 year later and says, Doc, why don't you just have a look inside? Because I feel that the voice has gone down just a little bit. And sure enough, we put in a scope and we saw this lesion on the left vocal cord, and which was a type 4 or a type 5A, if you will, because of this large IPCL. And of course, clinically, this is a recurrence. Narrowband imaging helps you to be sure about it and to tell the patient what you're going to do beforehand. So we went straight in, we excised this entire lesion. It was a stage 1 malignancy again, and the patient is now disease free again for another year and with no problem. So this is what we routinely do in our OPD. So all the patients who undergo laser surgery for a vocal cord growth come back, and there's really no point in just putting in a 70-degree scope or a flexible scope and seeing it, because early lesions you're going to always miss. You're going to get them later on. So our protocol is that the first examination is after 3 months, and provided the margins are free and we are sure that we have done a complete excision, and first three examination after 3 months, and subsequently we do 2 or 3 times narrowband imaging before calling the patient at longer intervals. But our experience is that without narrowband imaging, it's meaningless unless there's a big tumor and then it's very obvious. So this was again another tumor, another patient. I've put in these two pictures because I want you to appreciate that it's very difficult. The reason is that in a post-RT larynx, the post-RT larynx is the worst thing for a clinician to see, because these larynxes never appear normal. They always look edematous, they always look angry, and you're never sure that there is nothing. So this gentleman came with this type of a disease. He had a right vocal cord cancer for which he was radiated, And now you see that this is not a very obvious thing what he has on this right vocal cord, but you put in the narrowband imaging and you're sure that there's a recurrence here. And sure enough, we operated him and there was a small recurrence on this right vocal cord. This kind of a lesion, narrowband imaging, a very uniform flush of color, and you can be very sure this is a benign disease. You can be very sure this is a mildly vascular polyp. Also, what I really want you to appreciate is I want you to appreciate the left vocal cord, which is showing a keratotic patch. Now, this keratotic patch is not very obvious on this in the plain image. So, keratotic patches or small nodules, believe me, are seen so much better on narrowband imaging than on your routine flexible endoscopy or even stroboscopy. So, this narrowband imaging is my tool for diagnosing early vocal cord nodules. Okay, look at these patches. Now, these patches, you don't know what these are. Are they leukoplakic patches? You don't know. But look at this, and you see a lot of vascularity around and possibly fungal laryngitis. We do see a lot of fungal laryngitis in patients on inhalers and diabetics and even otherwise. Yeah. So this is a very angry, inflamed larynx. Now, when you're seeing on the right side picture, you're not really seeing any specific patterns, but do see a lot of blood around. You see bleeding and a very, very angry larynx. Now, we've all seen these type of pictures. You don't know what this is. A biopsy was done. This was tuberculosis. Again, you see white patches on the vocal cord. Are they leukoplakias? They are not leukoplakias. The inflamed cord all around. This is an acute setting, so probably fungal laryngitis. So, when you have this kind of a picture, there's a small nodule on this side. You see, there's a small polyp seen. Narrowband imaging enhances your vision so much that you can see the keratotic area on this side. You can see a small polypoidal nodule on this side. And you can generally, this is the tip of the iceberg, but if you see this part of the vocal cord, this entire vocal cord is showing keratotic changes. So, sometimes after speech therapy, this nodule might vanish, but these changes take a longer time to heal. And then the patient is going to ask you, my nodules have vanished, the voice is not yet exactly normal. And then you can just show the patient that this is area which is still healing, there's still time, continue with your speech therapy, and you will do well eventually. Um, okay. Now, this is a gentleman with hoarseness of voice and something is seen here which we're not sure what it is. A narrowband imaging, it is such clearly seen subepithelial cyst, and this can be operated, removed, and the voice restored. But with narrowband imaging, with this kind of a contrast coming in, you can see that so well. Another patient with a fixed vocal cord, and you see this image and this does not look like the malignancy. Mentally, if you imagine what you have seen before for pictures which I've shown for malignancy and this kind of a bizarre kind of thing, well, this is something different, and this turned out to be tuberculosis as well. It was a fixed vocal cord. His patient was counseled for all sort of kind of things. uh, we also thought this was a malignancy, but the biopsy showed uh, tuberculous laryngitis, thankfully for the patient. And he was treated with AKT and he was fine. Incidentally, the previous one had pulmonary cox. This fellow did not. His X-ray was normal. Hmm. Um, Earlier, I was talking to you about respiratory papillomatosis and how the IPCL patterns are a little different in both in malignancy and respiratory papillomatosis. Well, you look at this IPCL pattern, very fine and very uniformly distributed. So this is kind of uh, a pattern which you will see in respiratory papillomatosis. Some similar technologies are available with other manufacturers. iScan from Pentax, Chroma from the stores people, it's all there. And transnasal esophagoscopies are being increasingly done by ENT surgeons. And this narrowband imaging or iScan is being used in these patients. Now, this was a patient where we have done a esophagoscopy. Now, the patient was very insistent that I have something, very insistent. And twice he was scoped already by somebody else. And I was reluctant to put in a scope, but just because the sheer insistence of the patient, we put in a scope. And this was probably something abnormal, we're not sure. And the eye scan showed an abnormal area, biopsy showed squamous cell carcinoma. Patient was radiated. Thankfully, we listened to the patient. So, well, I was asked to do this presentation a little at the last minute, so I have not been able to get my data. But just to give you an idea, in these first 2 years of using this narrowband imaging, we could sample 94 patients. And out of those 94 patients, this was the age group distribution. And this was the type of diagnosis that we could pick up. So, out of this, eventually, when we kind of analyzed our data, uh, we could say that, okay, we were very sure that we could identify all diseases correctly with narrowband imaging. Now, of course, over a period of time, when you do a lot of narrowband imaging, that you're not going to have 100% accuracy ever. Okay, so but I think it's fair enough to say that most of your cases, this is going to help you in reaching a diagnosis. And of course, the sequence is to clinically see the patient, do your routine flexible endoscopies or rigid endoscopies or whatever you may, and finally use narrowband imaging to alter or change your diagnosis if needed based on more information. So, uh, I will very strongly kind of promote our young ENT surgeons and our consultants uh, to start using narrowband imaging in their day-to-day practice. Thank you so much.